Welcome to the Life's Best Medicine podcast, where we are finding hope and healing one episode at a time. No appointment needed, no rubber gloves, and no copay. Just a healthy dose of life lessons to help equip you for this wild journey we call life. Hey everyone, this is a friendly reminder that we are here for entertainment purposes only. We may not even be that entertaining at times, but this is not medical advice. Talk to your doctor, check with your healthcare professionals before making any lifestyle changes or medicine changes. What we're talking about is our clinical experience and what we've seen. And so if you really want our advice, you can consult us. You can actually consult me as a doctor, or you can consult my guest and get all your questions answered. But we can't give free medical advice because we can't pay our bills with that. But we can help to educate you a bit and allow you to think a little bit. And always reach out to your medical professional before making any lifestyle changes. Thank you. Hello, everyone. Don't say we didn't warn you. November is upon us. Here we go. This is the danger time of the year for our waistlines and our metabolic health and our diabetes and all that, all these temptations and treats and all those things. So I want to thank my sponsors here that help us to get back on track or to stay on track during these crazy times. First of all, Keto Mojo, keto-mojo.com. Thank you for having a great ketone meter and glucose meter that I use with my patients, and it helps us to determine if we are eating the right stuff and if it's truly keto or not. And also Health Code, they're doing great work. Both of my parents take it now to help with mental and cognition and mental health and all that. So Health Code, Get Health, GETHLTH.com. MedHealth is the discount code if you want to get that for your family members. Great ingredients, great shakes, chocolate and vanilla. So thank you to my sponsors. They're doing such great work, and I appreciate them getting these episodes out and sticking by us and getting us to the end of the year here. So thank you for listening and enjoy this episode.
Discover a new path to wellness at Arizona Metabolic Health. Dr. Brian Lenzkes offers advanced medicine and personalized care, treating the root causes of your health concerns, not just the symptoms. Whether you're seeking direct primary care, effective diabetes management, or medical weight loss, with a holistic approach, our team is here to guide you every step of the way. Visit ArizonaMetabolicHealth.com today to learn more about our innovative health solutions.
Hello and welcome back to the Life's Best Medicine podcast. I got this young chap here. He comes a little south of me here. Dr. Paul Mason, way down under, in the land down under. Welcome, man. It's great to see you.
G'day, Brian. Look, I'm very, very happy to see you again. We last caught up a month or so back over in the sunny climate of California, and it's good to see your smiley face again.
Yeah, in San Diego, man. You were on daddy duty there too at the conference, man. You're being the dad, giving like 10 lectures, question and answer stuff. You were a pretty busy dude.
Well, it was actually a fun time. It's a choice between, when I said to people, going to take my son across there, people are like, what are you going to do with him during the conference? And it's like, don't really know, but I hope something will figure itself out.
Yeah, you figured it out. San Diego's a pretty good place to have kids, man. There's pools and fun stuff and nice weather and all that. So
museums.
It was good, man. Museums. Yeah, you got to run around a little bit. You got to go visit a little bit.
Well, probably my attendance wasn't quite up to scratch compared to other conferences, let's be fair.
But you were giving half the lectures, so you couldn't miss too many of them. No, it was great having you. So what do you want to talk about, man? This is everyone listening. This is one of the smart guys. He's one of those guys like Ben Bickman and Jason Funk that I don't argue with. I just go, just teach me something, because like if I say something, he's going to know more.
Okay, well, here's your first lesson. Here's the first lesson I give to patients, and it's never trust a doctor. And the funny thing is, people then look to me and go, well, what do you think? And it's like, well, haven't I just told you don't trust me?
Yeah, never trust us, right?
The point is, and this is, I have no idea what we're going to talk about today, but one of the things I often talk about to people is when they come in, I say, nobody cares about you more than you. And the reason for that is all of us in the medical field are conflicted to some degree. Now, I try and have some awareness of my conflicts, but the reality is there's certain things that I might not say or I might nuance what I say, weight them differently based on my desire to remain a practicing doctor. So at the end of the day, our ability we like to think patients are making decisions based on informed consent. But the reality is sometimes we're not able to give 100% straight up information as frankly as what we would like to be able to give it. So at the end of the day, and it's really sad to say this, but people have to accept a degree of responsibility for their own health. And they have to weigh up the information themselves, and they have to understand the inherent biases in terms of the health professional who's giving them advice.
Yeah, I think that's really important because, we went through an era here where, they said, don't do your own research. It's dangerous to do your own research, right? Remember that. And it's
don't confuse your Google search for my medical degree, this kind of, high and mighty attitude. I mean, it's just straight out pejorative, insulting gaslighting.
Yeah, and I love it when people come in and they have their data. Go, look at this. What do you think of this study? What do you think of this? And I can look at it and go, oh yeah, I know that study is garbage, or yeah, this makes sense. But I always appreciate that someone put the effort in to look at it and say, look, I think I got this problem. What do you think? Am I right or wrong? You're the expert here. Let's figure it out together.
And here's the thing: often patients will teach you stuff. So you remember back in 2019 when I presented a couple of conferences, a carnivore conference and in Denver. And I gave a lecture on something called lectins, which is this crazy chemical in plant foods. Now, the way that came about is I had a patient come in and they said, what do you think of this Gundry guy? I'm like, sounds like nonsense. And I said, but I don't really know. I'm going to have to go and explore it. So I went and got the book and I read the book. And I'm like, wow, this guy actually has some science in here. And there does actually seem to be plausible biological mechanisms how lectins can actually harm our health. Now, putting to one side that the book, quite frankly, in the words of Ken Berry, I was chatting with him about it way back then, it was quite schizophrenic because the first half of the book tells you, oh, these plant foods are not so good for you. The second half of the book says, oh, eat plant foods. Now, of course, it's not that simple. Of course, there's a bunch of supplements and stuff like that you have to take to sort of make the plant food safer. But the point is, it's the book is a little bit disjointed, and I suspect that's why the famous book we're talking about is The Plant Paradox. I think the paradox within the book is how you can sort of say plants are toxic, eat plants.
Yeah, that is. But anyway, you're right. Yeah, I just saw him on an interview actually because my jury was that you were the first guy I heard talking about lectins. I'm like, wow, that is really interesting. So I have some people when they eat certain foods, they feel like garbage, and then they don't eat it and they feel good. These elimination type diets, which carnivore diet is the master elimination diet, so it makes sense if you're having all these symptoms. But I just saw like this. I just saw Gundry. He was on with a couple of vegan doctors, and they were just riding him, and it was pretty amazing because he had a lot of data and he was supporting what he was saying, and because he does have some paradoxes when he's talking about the blue zones don't matter. Then he's talking about the blue zones, like, wait a minute, you said they don't matter, and there's a lot of bad science. But the funny thing he was saying, because they were on him about juicing, and he said, I never said you can't juice. He said, you guys are just doing it backwards. He said, you're drinking the fructose, which is the poison. When you juice, all the stuff that's left over, eat that and throw away the juice and you'll be healthier.
Yeah.
That's a
well, the funny
point,
thing is,
right?
in all of this about lectins, that was brought to my attention by a patient. So, I mean, this whole thing is about this, I guess the power balance with doctors and their patients is sometimes wrong because, well, it is wrong because we should be on an equal footing. At the end of the day, I'm employed by the patient. And
that's the truth. Someone just said that yesterday. I will
do what the patient wants. Now, my opinion, if they want my opinion, they might not always agree with my opinion, and that's fine. But, I'll always be honest and transparent as much as I can. And while I've, just admitted that all doctors inherently have conflicts, I try to be aware of mine, and I'm open about them. And I say, look, there's, somebody might come in and want to talk about, this cancer or something like that, one of the C words. And I'll have to preface, what I'm saying with, I deliberately have to be careful about what I say here. So I encourage you to understand my inherent conflict here and to do your own research, but here's some resources that might give you some further education on that area.
So do you feel like you're under the thumb is that your medical partners, or is that the medical system? Like when you feel like you can't be free to say, here's my
I
opinion
think
on
the
this.
medical system,
Mhm.
I don't work with other people in a collective setting that is common in the US. I mean, I've seen copies of emails getting around saying your statin prescriptions, were too low. You need to up that. You're not meeting
Mhm.
your targets, so on and so
Mhm.
forth. So I'm familiar with all of that. So I don't get that, but we do have, the capacity. I've had several friends who have sort of been taken to task over some of the statements they've made. And I mean, I think it's fairly easy to avoid. I think you just preface everything you're saying. Well, this is not necessarily mainstream medical opinion. Do your own research. Here's some resources to have a look at. And if you have any questions, I'm absolutely happy to answer them. The ironic thing is that I tell patients they should hold their other health professionals to the same level of accountability. That if they're getting advice from a cardiologist, they're entitled to ask the cardiologist, well, why do you think I should take this drug? Do you have any evidence? Can you point to the science that suggests this is a good drug for me? And interestingly, the patients I speak to who have tried this, they haven't done it because it invariably fails. They get a blank slate. They don't get anything back in return. It's usually, I'm too busy. Oh, there's too much evidence to present to you. When it's like, well, I just want you to present me one paper. Like,
Yeah,
that
yeah,
doesn't matter if there's too much.
that's a
They come
great
up with
point.
these
That's a great point
vacuous
because
excuses.
and some of the meds they're using, I'm like, hey, ask the cardiologist who's a friend of mine. Ask him, what's the difference in the all-cause mortality? What's this? And then when they go in there, the doctor's like, you're right, I'm too busy. I'll get back to you on that. Like, because they don't know. That's why.
Well, I suspect a lot of them genuinely intend on getting back to them. And they probably go home that night, start doing a little bit of internet sleuthing, and then they're drawing up blanks. And like, there must be some heartbreak moments in the back of the scenes. But unfortunately, it doesn't seem that they're sort of, fessing up to their patients at the end of the day.
It's hard thing. And what do you? I think that's one thing of modern medicine is doctors feel like they have to throw drugs out there to protect themselves, right? If you have high cholesterol and you don't put a statin drug on, if you have high blood pressure and you don't do this, uh, you're protecting yourself, and then you have, like you said, someone's gonna write you letters and said, how come you're not prescribing
Well,
this
it's sort of
medicine?
guideline-based medicine where we feel that we get a degree of medico-legal protection, a liability protection, by following guidelines. But I came across a fabulous guideline recently, actually. It was a while ago. You're probably familiar with the concept of concussion. So, this was
Yeah.
made famous by Will Smith in the first Concussion movie. And the
You
sequel's
you
coming out
spoke
too,
on it.
Brian. They've
Oh,
got
is
a
that right?
sequel, yeah, starring Chris Rock.
Yeah, right. Yeah. Yeah, Will Smith helped with that one.
Right.
He had a hand in that.
Yes, he did. Was it a
Literally.
backhand?
Yeah, backhand. Yeah. Yeah.
So, well, interestingly, though, with concussion, there's a lot of money in professional sport, as you know, and there's a lot of incentive for some organizations to perhaps downplay the seriousness of concussion, the fact that a single concussive injury has long-term consequences. It's not this completely reversible, recoverable functional deficit that we thought about. So in sports medicine, we've got what we call these SCAT guidelines, SCAT, and we're up to the sixth iteration of that now. And they've historically been used as the guideline, the best practice guideline. But when I was going through the most recent one, and remember, these guidelines are still arguing about whether concussion is a structural injury. And I think the jury was out, probably 20 years ago on that. Concussion is a structural injury. But putting that to one side, the most recent guidelines actually explicitly state that following them doesn't protect you from it doesn't constitute a legal framework, a legally defensible framework for medical care, basically saying you can follow these guidelines and still be sued for malpractice. And I thought that was fabulous because that's a very first, ostensibly a document that used to be a guideline, but they don't really frame it. Certainly the SCAT-6 isn't framed as a guideline because it cannot be, because they're saying we are the experts on concussion. We've had this World Congress and everybody around the world, we've told you the best way to manage it. But if you manage your patients like this, you're not protected. And that's what all guidelines should be. They should say, Well, at the end of the day, you as the clinician, you need to be the critical thinker in the room. You've got to be the grown up here and do your own research and not just mindlessly believe whatever drivel is sold to you by drug companies or by other vested interests. We all know that these concussion guidelines, let's be fair, they've got a lot of doctors who work for big sporting teams and sporting codes themselves and so on and so forth. There is an inherent conflict of interest there. And one thing that people don't realize is that pens, for example. So, well, this one is from a radiology company, but I don't get drug companies coming to my office, which I'll tell you a funny story about recently.
You have to buy my own pens, yeah.
But here's the thing. So when I was doing my honors thesis in medical school, I studied medical school policies for controlling conflicts of interest, interactions with industry and pharmaceutical companies and so on and so forth. And first of all, the results, and I was lucky enough, I actually, even while I was a medical student, it was accepted as a first author publication in the Medical Journal of Australia, which isn't so big where you're from, but it's pretty good over here. And the medical schools were woeful, actually. They just don't control for it adequately. But there was one study I came across, and so they wanted doctors, they said, we want you to just tell us what your preferred medication is for treating blood pressure, for treating cholesterol, for treating diabetes, what have you. And the intervention was they actually used branded pens. And so they might have one, say, for Crestor or something like that. And before the study began, they said, oh, look, can you just fill out this questionnaire with your name, phone number, personal details, and then we'll get into the study. And when they filled out the questionnaire, that was the intervention. They would give them a branded pen or a blank pen. And they actually found that they were able to significantly influence what the doctors described were their preferred medications to prescribe based on whether they gave them a pen with branding on it during the filling out of their personal information. So basically, doctors are really, really easy to influence. We think, oh, well, I wouldn't be influenced by a simple pen. Well, there's research that shows that you are. And whenever we ask doctors, are you well, we'll start out and saying, is influence in the medical profession a problem? Are your colleagues influenced by industry and so on and so forth? Over 90% will say, oh, yes, it's a huge problem. As doctors, we acknowledge the scale of the problem. Then we turn it inwards and say, are you influenced by this? Oh, no. 90% will say no.
Not me.
So,
yeah, exactly right.
Flip the numbers on the head. So doctors appreciate it's a problem, but it's only a problem for other people, not for themselves.
It's a huge problem. I would tell anyone listening, Cheryl Atkinson wrote a book. It's called Follow the Science. And when you read it, your head wants to explode. Because it's all these things, all these topics. I just gave a talk for the Noakes Foundation. This law passed in 2008 saying, that you can't take a pen from a drug company. But the people who are our governing board at that time, in their bylaws says they can take any gift, any property, any money amount, any donation from any private, public friend, whatever, and they don't have to disclose it. And you go, wait a minute, you're the ones saying a pen's so taking trips to Tahiti is not gonna influence your decision making, but a pen's gonna make it was right.
In 2007, I think the US invoked what they called the Sunshine Act, with the idea sunshine being the best disinfectant, where they sort of, things above a certain threshold were actually having to be disclosed. And what was actually found was horrible. I mean, you found that a lot of the most influential expert doctors, they're on the take. Now, that we're not sort of, it might just be, a business class trip for a conference or an educational conference. But let's be fair, you go to might be somewhere in northern Japan, a ski season, ski region, business class flights, accommodation, all included. I mean, that's pretty awful.
Well, not only that, there's so many other things where nowadays the way the game is played is you'll see it on social media. A lot of these people are tweeting about the same thing at the same time. Well, that's odd. Why are they all attacking Jason Fung or Paul Mason or me? And then you go, oh, a new drug's coming out on Monday. And so they're not paid by pharma. They're paid by the PR firm that's sponsoring by pharma. So they're like, I'm not taking any pharma money. So it's not going to show up on the Sunshine Act, but they're getting paid to make these statements or send a message out, whether it's supporting a soft drink or whatever it might be. I go, that's not bad. Just exercise more. Of course, and it's tragic because people trust it, and nutritionists just got busted for that same thing.
And the problem is that what is being promoted is often just counterfactual. I think it's a nice way of just saying false. So when I said I've never seen a drug rep since I've been a medical student. I've never seen a drug rep. However, two representatives for a company that promote joint injections managed to sneak into my room the other day. They called up my receptionist, and I wasn't aware. And I was finishing. It was about 6 o'clock at night. I'd just finished the paperwork, and I walk out of my room, and in the waiting room, there's these two blokes there sitting in stylish jackets, just looking out of place, really. We've sort of got 1970s beige decor. And they're like, oh, yes, we're from, company X. We're promoting these fabulously expensive injections to cure arthritis. And I was like, well, last time I looked at stem cell injections, I wasn't convinced by the research, but that was probably about 7-8 years ago since I last looked. And maybe the technology has changed. So we had a bit of a back and forwards, and I sat down with them in the waiting room, and I just finally said, fine, okay, give me your best evidence that they work. And they pulled up a spreadsheet. I'm like, this is the best evidence. And it listed dozens of studies. They said, this is a double-blinded randomized controlled trial. This is a, progressive cohort study, what have you. This is a meta-analysis. And I said to them, just give me your best one. Just give me your best one. And they're like, no, this whole spreadsheet is the best evidence. I said, no, I want to actually be able to interrogate it. So they finally agreed on there was this double-blinded randomized controlled trial. Or I don't think it was double-blinded, but it was randomized controlled trial. So we went into my room and I brought it up. And the intervention, so they said, all the patients, they had knee surgery and then they got the injection. And I said to them, so how do you know that the outcome was due to the injection? They're like, well, look. And so, but they all had surgery, all of them. And they're like, oh, yeah. I'm like, okay, well, that's a bit of a fail. So then we went through 2 more studies in the same way. And they're like, what are you looking for? I said, I don't know. I'm just looking for where you guys have, the methodology is just fundamentally flawed and we can't trust the study. Just because you give it a label of a blinded randomized controlled trial doesn't mean anything. And we went through the 3 and they were all fundamentally flawed, like big errors that, a first-year research science student would have picked up. And the whole interaction, they're saying, oh, nobody's ever done this before. No doctors have ever worried about actually looking at the research. I was like, really?
Yeah.
And I said to them out of curiosity, how much of these injections you want me to give to the patients? They're like $12,000 each. And it's like, well, that's the price of a car, small car. And I happen to know my colleagues in my specialty who actually do promote these kind of injections. And ethically, I'm like, well, I know we're not talking about pharmaceutical companies, but this is still talking about the problem of money influencing the medical profession. There's a huge incentive. Imagine if you're a doctor and you could sell injections for $12,000 a pop. You can imagine that that incentivizes behavior in a way that it ought not. I mean, that's huge money.
Yeah, I had that. We've all experienced those things. There was a certain illness that was floating around a couple of years ago that was a big deal, and they had a test to detect it. And so I asked them, I said, look, I'm working at a college campus. If I have an asymptomatic person, I check it with them. Can I predict who's going to get this disease, this illness? And they said, yeah, you can. I said, well, give me anything clinically beneficial. Yes. I was like, oh, okay. So what you're saying is I could test my shoe or a dog or a cat, and they're saying you could test them. I'm like, but is it clinically helpful, right? Can I make a clinical decision based on this? And their answer was, doctor, you get paid for every test you do, you realize, right? That was their answer. That's the only answer. Because I said, can I have some literature on this? Because I knew you couldn't predict. It was a useless test because a false positive, false negative, right? So when you start looking at that and you see how much is done, how much money, like you're saying, is wasted, just based on nothing, based on no clinical benefit for the patient.
Yeah, I mean, people think that you're in it for the money, and the reality is, I don't think they've realised that there's other ways of practicing where you can make a whole lot more money than you and I currently do. I mean, I spend 1 day a week. I'm a neurosurgical assistant, and the point is, I could have just focused on that years ago, and I would have had my house paid off, and so on and so forth. Or I could have done all these injections that a lot of my colleagues are doing, absolutely lucrative. people don't realize that, medicine is a business where a lot of people make money, perhaps slightly unethically.
How do we fix this?
The whole system is broken.
Well, when you
I
go from
mean,
the very top, that's why this book, I look, I'm like when you have people are looking like they're saying half the studies are BS studies, right? That are published in these huge journals.
well,
And you know,
John
when you look in the
Ioannidis,
journals, yeah,
so he actually did a fabulous bit of research. So basically, he said, okay, I'm going to go for the 17 top medical journals in the world. And so the most that they have the highest, what we call impact factor. They're the most prestigious. If you get something published in them, that has the ability to change practice. So over a 13-year period, he looked at all the papers that were published in these 17 journals that were practice changing. That is, they had some new innovative finding. They might have supported a drug for a new indication or what have you. And he then analyzed, so he went from 2000, 2013, and subsequent to that, he said, I'm going to have a look at future research to see whether those findings can be corroborated. But I will only consider research if it is at least as good. The preference is that it has to be better quality studies reproducing the findings. And generally, most subsequent research on a topic will have a better methodology. And there was 6 observational studies published over this 13-year period that had practice-changing implications. When looked at in the context of whether or not future research of better quality supported them or not, 5 of those 6 studies were overturned from epidemiological or observational research. Even randomized controlled trials, they had a significant rate of about 1 in 4 of them were overturned. So the simple fact is that research is really not as good as we think it is. We're even us as doctors, we're often misled, and we're misled by influencers behind the scenes, perhaps, guiding what the research does. I don't know if you've heard of the Fourier study that was looking at a new drug called the PCSK9 inhibitors designed to lower cholesterol. So interestingly, one of the big problems with some of these studies is that the participant level data, so the data on the individuals within the study, is not made available for independent analysis. So people like you and I can't actually interrogate the data and see what it actually showed. Instead, we're given the interpretation of the researchers who may be associated with big pharma, may not be, so on and so forth. But we're not, they interpret the data how they believe they see it, and we get their interpretation. We don't actually get the raw participant level data. So for this Fourier analysis, and which they actually used to make a claim that these drugs might actually benefit all-cause mortality, they might make you live longer. So that was used to support that claim. So under a Freedom of Information Act through Europe or wherever it was, some independent researchers managed to get the participant level data, and they found that something like 20% or more of the causes of death within the study had been miscategorized. So, for example, if somebody died in a car accident, they might have said they died from a stroke or something. I mean, I don't know if that was a particular example, but that's a case of miscategorization of death, saying that what people died from was in actual fact something else. Now, if you've got a study where you're trying to get data on mortality and you're miscategorizing causes of death in some 20% or more of cases, does that not invalidate the results? And the question is, how on earth can that possibly happen? Here's a question for you, Brian. Can it be accidental?
yeah, it can't be. When you start looking at these, I mean, you
So you're
look at
braver
these
than me
things.
to say that, but
Well, it could. Well, it's a possibility that it's always possible that it could be accidental. But when you're trying to and I've seen that too, the data where they say, well, this one had a cerebral vascular event, so one person had a stroke, and they're using the different terms for the same outcome that was a bad outcome, but they go, oh, it's way down the list of the problems because it's all these different things. But it's, you know what I mean? Instead of if you lump all together, it goes to the top of the list as the bad outcome. So there's a lot of that. And, you know, I mean, we saw that recently where some girl's quadriplegic and they go, oh, she had a gastrointestinal infection. Like, we can't prove that that's what actually caused it, that intervention that we did. It could have been something else. She might have got hit by lightning in the middle of the night and we missed it, right?
Well,
It's
the
it's
thing
it's
is, and the
insane.
way these judgments are made, so they had an off-site study panel. So the doctors looking after the patient in the hospital saying, oh, this bloke's just had a heart attack. And then somehow, and the doctor has access to all their pathology results, their whole history, they've monitored them, their ECG, what have you. These on the ground, on-site doctors are making the initial call. And then they find that the study investigators then changed their cause of death. They determined that the local doctors actually looking after the patient made a mistake. Maybe they didn't have all the information or something. Maybe these people offsite sitting in another state actually somehow had better insight into what was actually going with that patient. The fact that they thought they knew enough to overturn the decision of a local doctor on the ground caring for the patient is just astonishing.
Oh, it happens all the time. I have friends who are trauma surgeons. They tell me stuff they see and what the diagnosis for their people will change it. The coders, the billers, because you get paid more for this diagnosis rather than that, right? So there's a lot of things. And did you die with this thing or of this thing, right? And so there's a lot of that. There's a lot of misinformation out there, and that's hard because you'll never know the truth. I mean, it's like you're saying, it's really hard to say, well, maybe just by chance you missed all these things, but you know, when there's a finite, you know, when some people are paid not to see things, maybe in your research, and there's other researchers that they can't get their study published. You work for a certain organization, and your outcome isn't what it's supposed to be. They can say you signed a contract with us, we're not releasing that data, you know.
Well,
And so
it's
that's an
funny. I
issue.
mean, there's a certain product, a certain probiotic product, which is very popular for treating inflammatory bowel disease. And it's based on a study that proves benefit. And I think that study had something like 6 participants. Now, a friend of mine, who I won't get into trouble, he actually thought that's interesting. So he actually ran a study with bigger numbers. And he unfortunately found that this supplement, which is, you know, quite expensive and sells well, did nothing for inflammatory bowel disease. When he went to publish, he was threatened with legal action.
Yeah, no, there's things like that you see and you hear, and I talk to a lot of people, and you go, oh gosh, because then you don't know what's real and what's not real, and how do you? I mean, really, ultimately, and I'm an old man compared to you, man. So I've seen all these new miracle drugs come out. They go, this is going to cure everything. And then they go, uh-oh, I'm having bad outcomes. I'm not going to deal with this anymore. I don't care what this study is because it's a miracle. And then you realize, oh, there's other things that can happen in the post-marketing, right? So I'm more of a hesitant. I don't just jump on the newest bandwagon. I'll go, let's see. I'll talk to my friends to see how their numbers are, how their patients are doing, because I don't want to use my patients as a guinea pig.
Mhm.
You know, so a lot of those miracle drugs are no longer on the market, but they made their money before it gets taken off, unfortunately.
Well, and that's the thing. It can take a long time. I mean, the very first, I'm sure you've heard me talk about troparinolol, which is the very first cholesterol lowering drug to go to market. And that was only on for a few years. But the simple fact is it was causing, you know, increased heart attacks, irreversible, you know, blindness via cataracts and stuff in all the animal models before it was released. And then when it got released, it did the same thing in humans. And then it got taken off and they got sued, and they actually, you know, they were charged with covering up in the civil court cases, accusations were that they knew about this data, they deliberately covered up the data, so on and so forth, the side effects, and that they were all found guilty. Now you've got something like Baycol. Remember the superstatin released by Bayer? I think they paid out over $1 billion in compensation for, you know, unleashing that onto the world. And this whole concept of what makes a statin a superstatin, well, it's the dose that makes the poison. This statin just worked too well. It did exactly what all the other statins were intended to do, inhibiting a enzyme called HMG-CoA reductase. and preventing your body from synthesizing cholesterol. This super statin just did that too well. And guess what happens when statins work too well? People die.
Yeah. Yeah, all those, Bextra, I mean, one after another after another. I think the last I saw, and don't quote me on this one, but it was somewhere in the neighborhood of $88 billion has been paid out by these companies over these last whatever
Wow.
10 or 15. $88 billion. It's unbelievable. I was just listening to it last night driving, and I was like, "You've got to be kidding me!" Some of these are huge amounts, and it was good, but
And the drug companies are just chasing money. So, do you know the
88
story
billion.
of
But guess what?
statins?
Not one CEO spent a day in jail
And
with
that's probably what needs to fix the problem.
or paid
We need to,
financially out of their own pocket. The company gets nailed, but the CEO gets his bonus, and they're off in the sunset doing their thing.
the
It's
legal
incredible.
protections afforded by corporations allow people to get away with really egregious behavior. So I think you're right. If
Well,
people were found,
Oxycontin, all these drugs. I mean, there's a list, and it's incredible when you see it all in one place. We can have you make a spreadsheet, and you can look at it, and your hair will fall out looking at it.
well, do
That's what
you know
happened to
the
Tro. Tro
story?
probably did that, and Tro's hair all fell out.
Well, the story of statins, how they were first developed, because we had this lipid heart hypothesis. And we said, oh, we've got to lower cholesterol in the population. That'll help people. Now, that was complete and utter nonsense, but there was a race on. So there was this new fungal mycotoxin, basically a toxic compound of a fungus. And the Japanese lab Sankyo was the first one to actually start researching this. And it was this Japanese scientist, Akira Endo. And the Japanese, they were studying it, and they used to use beagles as a model for their drugs to assess their safety. And too many of these beagle dogs were dying because of cancer. And they said, well, this is clearly not safe. So they stopped doing it. And then they were in competition with a US company. And the US company, they stopped investigating it because they were racing at the time after they said, oh, Japanese scientists said there was too many cancers, we shouldn't do that. And then a couple of years later, internal agitation within the company said, surely they couldn't have been cancer, those Japanese. You can't trust those scientists. They don't know what they're talking about. It was something different. It wasn't cancer. They were wrong. It's another example of people offsite making judgments. So they ended up developing the statin and launching it. And that was the very first statin that was unleashed onto the world. The very same statin that the Japanese scientists stopped researching because it was killing people. And Akira Endo, he was actually interviewed years later and about his health. And it came up that he had high cholesterol. And they said, oh, you've got high cholesterol. Well, you must take a statin. And he didn't really say much. He just gave an ancient Japanese proverb, which translates as the indigo dyer wears white pants. Basically, a reflection of the fact that the indigo dye is quite toxic. And that was his answer.
Yeah, it's and then it's probably the standard of care in Japan too, I would think.
Now, interestingly, drug companies are under a lot of pressure for this transparency. I told you they're hiding all the data and so on and so forth. So there are some data sharing agreements that the large drug companies have actually agreed to be a part of. Now, interestingly, and basically, however, when some independent investigators tried to use these mechanisms to get the data, they failed. And the reason they couldn't get any of the statin data from Sankyo, this drug company who was basically who Akira Endo used to work for, is that the data on statins was specifically excluded from the data sharing agreement. They're going to great lengths, and they also implied that they no longer held the data. It was also suggested that they've destroyed this data. Now, why?
Yeah, I mean, all these questions. I'm not giving you another answer, man. I'm not falling for that again. Yeah, so there's a lot of things that we all I wish we knew more answers and we could have good data and good knowledge on. But I think it's as we get older in medicine, the more we're around, the more jaded we get, the more we're like, I'm gonna wait and see. I'm gonna wait and see and make sure. Unless it's life and death, and you go, okay, we got no choice, or we got some.
Well, the thing that infuriates me is that on social media, there's two things. So I get a lot of doctor ads. They've flagged me as a doctor, and I get, give your patients this, give your patients that, so on and so forth. And I mean, we just get pressured day in, day out, which is, and I know, and I look these things up, and they're complete and utter nonsense. I'm sure you get the drug company. You cannot avoid it as a doctor.
Yeah, it's all just like you're saying, the pin. The more you see something, go, oh yeah, I just saw something on that on social media. Maybe I'll write for that medicine. Yeah, I think people are biased that way, and it's hard. And and a lot of it, like you said, is the guidelines where they go, this is the protocol you use at this hospital, and you don't question it. And so when you have bad outcomes, you go, oh, it's the same thing as when I first started looking at, and you made that point is, how we learn from patients. I learned about metabolic health through a patient who lost 40 pounds doing the fast diet. He would do 5 days eating regular, 2 days of fasting, 500 calories or less, no carbs. I'm like, you lost 40 pounds doing that? That's impossible. And I'm trying to lose weight all the time doing the ADA's diet and drinking green shakes for breakfast, right? I'm like, none of that's working for me. My sugars are going higher. But then I start looking, I'm like, okay, let's see what this patient's talking about. Let me tell him, I can't say he's doing the wrong thing. It's working for him. I'm not going to tell him it's wrong, right? And so I go, let me
See, that's a
let me
degree of
research this.
humility there. I mean, if only other doctors had your degree of humility, where I've had dozens of patients who have had fabulous results, and their doctors say, well, that's all fine, but you're killing yourself. You've got to stop.
Yeah, if you
It's
come
like
off
you
six
might have
medicines
lost
and you
weight.
come off insulin, just yesterday I had a lady, I just posted about it. She lost 38 pounds, came off insulin, came off all like 4 blood pressure meds, and her mood med, her joints don't hurt. She's feeling great. She's off everything. And she had no Hago who helped you. She said, I saw a video by Jason Fung. And I'm like, that's funny. That's who I first looked at. I'm like, what's this fasting thing? Who, of course, is going to come up as Jason Fung. And then he starts talking about metabolic health and insulin resistance. You go, oh my gosh. And then this whole bag of worms is open now. And we see mental health getting better, sleep getting better, all these things getting better. You go, okay, your knee pain. Like I have people that were scheduled for knee and total knee replacements. They go, my knee doesn't hurt anymore once they lost weight and got their inflammation down. So should I inject them with a $12,000 injection and not talk to them about lifestyle?
How has medicine been distilled down to one marker, LDL, being representative of total health in the face of energy levels, sleep quality, libido, pain levels, everything else that, what
Life
makes
and
you feel
life
healthy?
enjoyment. Yeah.
Yeah. So, how has health come down to a single metric of LDL at the exclusion of everything else about, how you genuinely feel?
Especially when you start looking at data, outcomes data, when you go look at like high triglycerides, high insulin, that's a total disaster waiting to happen. And no one talks about it. Why? Because you don't have time to say, hey, how's things at home? Are you stressed? How's your job? They're like, I got 12 minutes. Okay, here's a drug, here's a drug, here's a drug. You got hypertension,
So it's 12
right?
minutes the standard consultation.
In the US, not for us outside the system, but if you work for a big corporation, it's 9 to 12 minutes per patient that they have patient time with the patient, right? But they still got to
Yes.
write their notes. So if you have 15 minutes, like you got to write your notes. I'm going to write that in a minute. It's going to take time, right? So you have to document. So either that or they turn their back to the patient and type the whole time the patient. I've seen that too happen. So I don't know how it is down below, but down under, but up here, yeah, inside the system is really hard, on follow-ups. And that's why I
Well, I
was
mean,
going
I don't
crazy.
think it's much better, but I don't work within that system. So,
Yeah,
I mean, what I've figured out is that I need 45 minutes to do an initial consultation. And even then, it has to be well prepared. I mean, patients will have had to complete a 10-page medical questionnaire beforehand that I can screen if they've got any pathology result. It needs to be an efficient, even then running, 45 minutes as efficiently as possible. It's only just enough time to really get a handle on a lot of what is going on for most patients.
exactly right. Yeah, you need it. I'm slower than you. It takes me an hour. I sit down for an hour. I go, let's go through your medical problems. Let's go through. Then we could come up with a game plan and say, oh, let's get your labs and let's see where this and where your insulin, triglycerides, HDL, like you're saying, these doctors, it's amazing to me how they can look at you and go, yeah, you don't need an A1C. You're fine. I could look at you and tell. I'm like, really? I'm not that smart because I have a lot of people who look like a fit Paul Mason that come in with their A1Cs at 7 or 9. You go, uh-oh, we got a problem. Let's look at that,
Yeah.
right?
And that problem is increasingly common. I mean, so we talk about something called LADA, latent autoimmune diabetes of adulthood. It's basically an adult version of type 1 diabetes, and where the body cannot make enough insulin. And the problem is that you need insulin for weight gain. We know that's a major cause of obesity. So people who don't make enough insulin, they often get very skinny. But you also need insulin to control your blood sugar levels. So we often have these people with, quite outrageous sugar levels who are looking slim. And we're making the assumption, oh, you're skinny, you're fine. And probably about 15% of people who have been diagnosed with type 2 diabetes because they've got high sugar levels actually have an autoimmune component. And this is a huge iceberg of, undiagnosed medical condition. And it's very different to type 2 diabetes, where the insulin is not working. So they lead, whether you've got deficient insulin or just lazy insulin that doesn't work, the outcome in terms of your sugar levels is still the same, but it affects your body habitus. One of them you'll get skinny, one of them you'll get fat.
Yeah. So why do you think we're seeing so much of this autoimmune type 1 diabetes in adults? Why do you think this
Well,
number is
first of
going up like
all,
crazy?
it's not genetic. You look at any of the
Yeah.
literature, the first thing they say is there's these genetic tendencies for these conditions.
Mhm.
And yes, but if it's genetic, that does not explain an exponential increase, which we're seeing over the years. Simply put, the genetics across generations are remarkably stable. There's only very small rates of mutations. So if it's not genetic, it has to be environmental. And what has changed in our environment? The biggest factor that I believe is contributing is actually chemical and pesticide exposure. So in the last 30 years, the World Health Organization estimates that there's been about 11 kilograms of glyphosate, known as Roundup or Zero, used for every man, woman, and child. And there's also been an exponential increase in that. They estimate that 70% of that's been used in the last 10 years. And because this is like antibiotic resistant, there's, these pathogens develop a resistant to antibiotics. We need to use higher doses of antibiotics or different antibiotics. This happens with weeds too. The weeds develop resistance to Roundup, so that farmers have to use more and more Roundup or more, paraquat or whatever chemical they're using. And this exposure is absolutely catastrophic. I mean, for example, so Parkinson's disease. Do you know how we cause Parkinson's disease in an animal model? If we want to study it in a lab, we have to cause it. So we can give dogs Parkinson's disease. We do two things. We give them pesticides and we feed them peas. So peas contain these chemicals called lectins, and the pesticides actually damage the gut. And what appears to happen is that when you damage the gut lining, this chemical from peas, this P lectin, can actually travel up the nerves, the vagus nerve from the stomach, and get into the brain. And they've proven this. They've actually cut the vagus nerve in some people. We used to do that to treat stress, a bad idea. And we found that in Denmark population study, the rates of Parkinson's disease were more than halved when in people that had this operation. They've also, in animal studies, they've attached a little fluorescent molecule to the P lectin. And then they've caused the Parkinson's disease, and then they've euthanized the animal. And in the part of the brain that's affected by Parkinson's disease, the substantia nigra of the basal ganglia, they've actually detected these little fluorescent molecules that they fed to them in peas, proving that they actually travel up into the brain. But pesticides is the major reason. In Australia, farmers can spray Roundup on a crop 6 days, wheat crop 6 days before harvesting it. And that's not even the problem, because it's the problem when they spray it on a crop that is rapidly growing. So when we talk about genetically modified crops, the big problem isn't the fact that they've made modifications to the genes. I don't think that is, because you have random genetic variation just from crossbreeding and so on and so forth. The big problem is that the genetic modifications they make are to make them resistant to pesticide, so that you can smash a crop with a pesticide and it stays growing and it just decimates all the weeds around it. So you end up with this, what we call this monoculture. And The genetic modification actually has allowed the increased use of pesticides, which is utterly catastrophic. And I think that, that damages the gut. Look at the Parkinson's disease example. Do you think P lectins can normally travel to the brain? No, they can only get to the brain when they're combined with a pesticide.
Yeah.
And we're having huge levels of pesticides in our food. And a lot of, low carbers, don't be smug. Because what kind of fruits do low carbers eat? Berries. What are the most heavily contaminated fruits with pesticide?
Berries.
Yeah. So, I mean, this is a huge problem. We've even discovered pesticides, just in case a carnivore wants to get smug, in the meat of cows, in all meats, in the lung tissue, in the liver tissue.
Because they're eating the hay and grass that's covered.
Well,
with
often,
pesticides.
so theoretically it shouldn't be, but we now have a problem now because some farmers, they grow what we call cover crops. So when you plant a legume into a field, it actually binds, it's what we call a fixing crop. It binds nitrogen from the atmosphere and puts it into the soil, and it helps regenerate the soil. So a farmer plants a legume cover crop, then they want to get rid of it. So what do? They kill it with Roundup. And then how do you get rid of that debris? Send the cows in.
Yeah. And the pigs and everyone else. Yeah. We're looking at that. And I agree with you 100%. I think that's it's the gut microbiome. I mean, if you destroy that in the gut lining, autoimmune diseases go crazy, inflammatory
well, it's
bowel
not just
diseases,
what it
all these
does
kind of things.
in our gut. What about what it does to the soil? Okay, so thought experiment. When you grow food, it has we'll say grow a crop of wheat. That has some nutrients in it, not great compared to meat, but it's got some nutrients in it. Where does it get the nutrients from?
The soil.
Right.
It's pulling them out. And then you keep doing it over and over.
So we pull the nutrients out of the soil. But, the soil's meant to grow stuff, right? So we must have a natural mechanism to replenish the nutrient level in the soil. So where do those nutrients come back into the soil? So where do they come from? Well, they come down from breaking down rock and stone and clay and sand and so on and so forth. Now, how does that breakdown happen? Well, you need an incredible microbial, fungal, protozoal kind of diversity of growth. This complex network will actually help replenish the nutrient status of soil. Now, what do pesticides do? They destroy that natural ecosystem within the soil. Now, one of the other things which is fascinating, I had a farmer for a patient a couple of weeks ago, and he was talking to me about the standard fertilizers they use, where they just put on, sodium and potassium or whatever it is, nitrogen.
Nitrates. Yeah.
And NPK, I think they call it, nitrogen, phosphate, potassium. And he was saying that he's inherited some fields. Then they did a nutrient test on those fields and they were atrocious. And then they started using organic fertilizers, so basically manures and blood and bone and stuff like that, and saying that when you go away from the synthetic fertilizer to the organic fertilizer, the nutrient state level of the soil came up. So it's absolutely not just the pesticides that's destroying the nutrient quality of soil, but it's also the use of modern synthetic fertilizers. And unfortunately, the consequence is that the food we're eating is deficient in nutrients compared to what it used to be. So copper, for example, in some studies is down by more than 75%. So you'll need to eat 4 times the amount of a particular food to get the same copper that you used to. And this is a problem that affects everybody. So it affects food that's grown, but it also affects food that's raised, so, pastured animals and so on and so forth, because the grass is going to reflect the nutrient composition of the soil. Now, fortunately, most animals that are grass-fed, those fields, the farmers aren't wasting their time applying synthetic fertilizer or pesticides to them, which means that they're relatively healthier. But in general, you can have some, regions, just as an aside, some regions of the world. Australia's soils are known to be particularly poor in nutrients. So we've got an area called the Central Tablelands where a lot of food is grown, which is quite deficient in boron. And boron, it's not considered an essential nutrient, but it should be. And there is actually a movement arguing that, pushing for this. So probably in the next 10 or 15 years, we are going to see that boron is considered an essential nutrient, and we'll start seeing foods fortified with it and increasing awareness for these regions in Australia that are deficient in boron. In animals, we know that boron deficiency can cause diseases. There's a fancy diseases called the osteochondroses, like problems of the hip, like Perthes disease. So if a farmer sees a pig limping, they'll often just whack some borax into the feed because they know that that'll fix the hip and the hip will get better. The pig will stop limping.
Yeah,
But
they
the
were doing
point is,
studies on boron with osteoporosis, I know, a while back, but I don't know what the outcomes were on that.
well, in a deficient population, it's going to help. There's actually randomized controlled trials looking specifically at osteoarthritis. And to my mind, it's the only supplement that's been clearly identified in double-blind randomized controlled trial to actually reduce the pain of osteoarthritis. And I suspect, clearly that just reflects a deficient intake in our diets. But the point is that pesticides lead to impair the nutrient composition of soil, as well as causing increasing risk of autoimmune diseases and what have you. And there's a lot of people who would argue and are arguing in court and getting payouts that pesticides can also cause cancer. Combine that with synthetic fertilizers, further depleting soil of nutrients, and just the natural variation in Australia. We've got nutrient deficient soil a lot of the places. So I think a lot of people are simply not having the required nutrients in their diet. And health, I mean, rather than giving people drugs, if I was to ask you, if you've got somebody with a chronic disease, is it more likely to be a pharmaceutical deficiency or a nutrient deficiency? I think I know what the answer would be. And as
Well, it's
doctors,
just crazy. Yeah, it's
we
just
ought to
crazy you're
be
saying that because
looking.
I just interviewed this lady earlier today, Dr. Kaplan, a PhD studying nutrients, and she says micronutrient deficiency is a massive problem in mental disease, depression, anxiety, stress, agitation, ADD, and they have tons of studies looking at this, like supplementing and see what happens, and it's pretty remarkable that the differences they're seeing in outcomes.
And we've also got beautiful science and mechanisms. So, for example, to produce dopamine and serotonin in the brain, you need certain enzymes working, and cofactors for those enzymes include iron and B12. So if you've ever had a patient who's been iron deficient, you'll know that they just don't feel 100%. There is biochemical reasons, physiological reasons why somebody who's iron deficient would feel a bit flat, because they don't have the same level of neurotransmitters kicking around. So, zinc can have the same effect. B12 can have the same effect. So the fascinating thing is not that, that micronutrients can do this. The interesting thing is that given that it's in every single biochemistry textbook where these pathways are well laid out, why it's not known by every single doctor, and why we don't, people who come in with depression or cognitive impairment, why they're not all getting iron studies, B12 studies, zinc studies, micronutrient analysis, why we're not actually intervening like this. Why our first response is to say, oh, I'm a doctor, I'm a walking prescription pad, let me write you some, Prozac or what have you.
She said the same exact thing, the same nutrients, cofactors, all that. She was surprised when I use the term cofactors. Like, you're a doctor, you know what a cofactor is. Like no one knows those things. So yeah, exactly what you're saying is that we have to start looking at that bottom up and say, what's our nutrition like? And we're learning a lot and we have a long way to go. So I think we offended just about everyone. We got our goals in today. Yeah. So I got to ask you, since you're on this podcast, for Paul Mason, MD, what is life's best medicine for you? Like, what keeps you going? What keeps you out of bed and fired up? And, or where do you go when things are bad? You're going through a hard time. Like, what keeps you going, man?
I tell you what, my guilty pleasure, which I don't really engage in enough, is I like to get out on the tennis court and, just have a hit. I mean, when you actually look at, it's funny because, we're doctors, so we've got friends who have gone into specialties and earning a lot more money. They're not driving Ford Focus or anything like that. They're driving Ferraris, they're living on the water edge. But when I think about what makes people happy, it's like, what do I enjoy? Well, it's social connection. It's getting out, playing a game of tennis, spending time with my kids. And honestly, this sounds silly, but every morning when I get up and I eat the same breakfast, I eat a steak, a nice fatty steak. And honestly, I look forward to it and I enjoy eating it. So I think it's a, and I do, I try and avoid doing things, I don't smoke, I don't do drugs, so on and so forth like this. So I, what keeps me going? Well, I'd like to think it's a, just a healthy lifestyle. Now, one thing I don't do as much as I ought to is exercise. And I think that's probably like yourself. We tend up, we burn the candle and we get overworked. And sometimes we don't make enough time for ourselves. And that's something which, one day in the future will probably correct.
Well,
But
tennis is activity, like getting out doing stuff, and you obviously look at you're a fit dude, right?
well, here's the thing. A lot of people assume I exercise a lot more than I actually do. And I do frequent small level exercise. So I've got a chin up bar and dip bar. So, every day or two, I'll go in and do a set of dips and a set of chin ups and maybe some push ups or what have you. Now, for the same level of exercise, when you're on a healthy diet, you will build more muscle. So I'm actually able to maintain, so I'm, mid 40s. I can maintain as much muscle now with far less work than I did when I was in my 20s, simply because I'm on a healthier diet. I used to work out a hell of a lot more than I do now. And if I ever worked out like I used to, I would have to buy some new shirts.
Yeah, I mean that's it. And then there's studies saying if you could do these 15 or 20 minutes or 1 minute here and
Two
there,
minutes.
yeah,
Yeah.
2 minutes, like things just doing it, getting up off the couch, moving around, jumping around, doing fun stuff, playing with your kids, doing things. So I mean, you've learned a lot over the years, and your wisdom and knowledge base is mind blowing. Like all the stuff you look at, you have your finger in everything, and that's good. It's a good thing to stay looking at that and saying, what about the micronutrients? And I think that's it. When you have critical thinking, you go, okay, let's look at why is it normal to have high blood pressure? Is it normal to have all these things? Should we look for the root cause? And you do a great job of those things. And your patients are fortunate to have you, man.
Well, thanks, Brian. Really kind of you to say that. And I mean, obviously, you're doing exactly the same thing with your patients. Basically, you're giving them academic honesty. You, and I think as doctors, I think if we can be honest with ourselves and with our patients, and that's all we need to do. I think, that's probably an essential requirement, and dare I say, probably almost the only requirement to be a good doctor.
I think that's it, man. We owe to our patients, hey, here's the best information I have right now. This is what I think. Maybe we'll change and to be able to say change course and go, maybe we do look at these things. Maybe we do look at micronutrients. Maybe we look, try different things. And when you are arrogant, like you said, you learn from your patients. When you're arrogant and you know it all, and patient comes and say, hey, since I've been taking that medicine, I'm having this problem. And they go, that's not from the medicine. It can't be. And then you go, let's
Oh,
stop it and see. Like so often we see that, and stopping the meds, they go, oh, I feel great again. It wasn't in your head.
but your LDL.
Well, we're not gonna say just that medicine, but yeah. So Paul, where do people track you down if they wanna learn more from you,
Well,
find you?
I've got a website which I has recently been updated, but still not much on there. I do Twitter from time to time, X.
Hmm.
So, and any interesting findings, which I've got a couple of things I'll probably post on there later today. I came across in the last week or so.
All right.
Low Carb Down Under is a YouTube channel run by my friend Dr. Rod Taylor, and there's a few of my lectures up on there, and not just my lectures, but a bunch of people. Um, you know, there's some that sort of push the boundaries a little bit, perhaps too much, but in general, excellent content and well worth a look. And yeah, otherwise, Twitter, Low Carb Down Under. And
Yeah, awesome, man.
hopefully one day I'm going to start my own podcast.
All right, man. All
So,
right, we need it. Yeah,
well, actually,
we got
I'll
all
run
kinds
it
of people
by
in there.
you. You're the podcasting professional here. So I thought that, if I look at any of my lectures online, there's a whole heap of vegans who have been upset and they make comments. So I thought a good title for a podcast would be actually responding to those comments and just reviewing them and the content of lectures, and not just mine, but anybody's. And we'll call it Trolling for Health.
Very good, man. I like it. I like it. Then you can have people on it, have a discussion with them, and go, so why do you say that? Let's look at the data. And I
Well,
know
here's
you,
the
it would be
thing. I've never been able to. There's a few, high profile cardiologists and so on and so forth. And whenever people, in those kind of positions, whenever I've actually asked to have discussions with them or debate them, so on and so forth, it just never lands. So, I mean, Mr. Lane Norton, if you're listening, you're, Dr. Allo, Ethan Weiss.
Oh, I will pay to hear these. I will pay money to hear these discussions, right? Because I know, there's a lot of people out there, all these same names. Dr. Bellardo, I would love you to have Dr. Bellardo on to talk to you too. There's a lot of good people. That would be fun. You could do it as a pay-per-view event because it would be a lot of entertainment for everyone.
But it doesn't happen. I mean, unfortunately, Lane is, for the last 18 months, he's agreed, but he's just been unfortunately too busy to talk to me. He will let me know when he has the time. I don't think he's ever going to have the time somehow. He hasn't quite managed to reach out to me again. So if anybody wants to knows Lane, then, ask him.
Yeah, I would love that. Lay the gauntlet down. I would love to see that. And that would be a lot of fun actually to see that, because it's that's one thing as we're leaving here, in medicine we have to have different points of view and be able to have a discussion and go, okay, where's your data, where's my data, not suppress the other side, just say let's present what we got, what are your outcomes, what are my outcomes, and let's have a nice discussion, right, and not get personal and argue and suppress things. That's what's made me crazy over the last few years. I go, that's dangerous misinformation. Well, let's hear it. Does he have data or not? Professor Noakes, Gary Fetke, all these people who went through all this stuff, when they presented their data, they said, oh, they have data. They know what they're doing. They're not idiots, right? So I think that's something we can all learn from. So I appreciate having you on and having these offending big food, big pharma, all these guys, and let them come and defend themselves and say how we're wrong. They have more money than us. That's the only big problem we got, Paul.
A little problem.
Yeah, it's a little problem, but either way. So everyone, be kind to yourself, be kind to others, keep an open mind, look at all these things. If you're not eating healthy, look at these things, kind of taking out the processed foods. And I look at a lot of food a lot differently now than I used to and go, I don't think so. Not very good when you understand the consequences.
Just to that food thing, sounding like a hippie doctor here, eat organic, minimize pesticide exposure.
Grow your own stuff in your own backyard.
Well, that's, we've got a lot of some big patches of dirt in my backyard for that purpose right now.
All right, man. All right, everyone. Hey, and have a great weekend. Thanks again for joining me late notice here it's a Saturday for you and a Friday for me. You're a day ahead of me. That's why you know more than I do. You're a day ahead of me, man.
Oh, that 24 hours has accumulated most of my knowledge, actually.
Take care.
Thanks, Brian. Good to chat.
Thank you for listening to this episode. We greatly appreciate your support. We would greatly appreciate a positive thumbs up on all of the platforms like iTunes and Spotify or wherever you're listening. And we just thank you for our Patreon supporters. We greatly appreciate your help in getting this message out. We think there's a lot of important information. And hopefully this helps you. Have a great day, and thank you for listening, and thank you for your support.